Thanks very much, John. And I want to thank Christine and the crew, the planning committee for this great meeting. This is so inspiring to me. I can't even tell you to hear all the innovative work that you all are doing in terms of solution problems to our infection control issues. And then, of course, get to see people like Andy and Russ and people I've admired forever in the field and people I haven't heard before, but I've read about their studies. So this has been a really fantastic meeting for me to attend. And thank you for staying at this last session and listening to regulatory content. That takes real passion. So before I was an IP, which I've been for 35 years, I actually was an ICU nurse down the road at Harper Grace Hospital in Detroit, at Detroit Health Centers. And I was there during one of the first outbreaks that the legendary Judine Bartley, I have to not cry when I say, legendary Judine Bartley covered. And she came into our 6-tower ICU, and the outbreak was just all over the place. And she was like, you know, telling this very difficult surgeon who was in charge of the whole ICU and really didn't take anybody's word for anything, what they were going to do and how they were going to do it and when they were going to do it. And I was pestering her all the time as an ICU nurse, why are you doing this? And why are we doing this? And how's this happening? And she said, you have to come be my IP because you just, you know, you're asking so many questions. So that's how I actually got into the field. And before that, just because everybody's talked about their history, or several people have, I actually grew up on a dairy farm down the road about 4 hours. So it's great to be back in Michigan. I don't get up here very often. But when on the dairy farm, I learned a lot about sanitation, right? Because the milk tester would come once a month, and he would test the milk to be sure there wasn't coliforms in it. And we had to whitewash the walls because when the milk tester came, everything had to be looking sanitary. And we had to worry about the storage of the food and the corn so the cows didn't get sick, because we 300 head of cows twice a day. Besides the grain farming, and we had to make sure that the air quality was good, because when my brothers would go into the silo to pitch silage, I had to stand outside to be sure they didn't pass out from the gas of the farmer's lung till my dad sprung for some mask when we were teenagers. So, you know, I think I was destined for this field, I might say, but that's just to give you just a little bit of difference, just because you stayed for the end of the day, my history. Okay. Meanwhile, back at CMS, I have to say I'm a contractor. I'm a federal contractor. So anything that I say, my views, my opinions, these slides expressed in this lecture by me reflect no official policy or position of the U.S. government or any of its agencies. Okay. Now, what I am going to talk about today is really the regulations, where they're coming from, why we say what we do. There's a lot of misperceptions, misconceptions about regulations and what we have to do, what we don't have to do, and why we have to do them. Really what's coming, all these issues we're dealing with today, how we can move those forward. I've kind of gotten used to the idea that when I used to speak for University of North Carolina, everybody would smile at me the whole time and nod. And then when they started introducing me as coming from CMS, everybody would frown at me the whole time. So that's okay. I've learned to deal with that. But let me just tell you why CMS is so important and why we've come back to this subject so many times in the last 2 days. And it's really because they're the biggest payer, right, of all healthcare in the U.S. And I know we heard from the British system a little bit, so we're going to kind of contrast and compare the British system to the U.S. system. We know that they cover everyone, but we cover 1 out of every 3 Americans with our Medicare, Medicaid, and children's programs. 1 out of every 3 Americans are covered under this. So about 65% of all U.S. healthcare dollars come from the federal government. So, of course, they want to see that they're getting their money's worth, basically, is what it comes down to. 105 million beneficiaries paying out $1.2 billion. And I've actually been very impressed working at CMS because, you know, we all hear CMS and you know, the DFS, whatever your state survey agency is, how that relates to, you know, them coming in and being, you know, really rigid or really behind. But I've been very impressed with the quality of the people and the passion of the people in the federal government, trying to make sure that we do better care, that we do have access to all coverage. These are the folks that make sure that we don't have somebody stopping people at the door to come in. And then, of course, improved health is their motto. It really comes under kind of these 6 big categories that CMS is responsible for. Most of my work is on the left side of those 3 things, with the clinical standards groups, with the survey and certification group, which is where I'm embedded with, and then the quality improvement people who I work with on an ongoing basis. But, you know, we've heard in the last 2 days, oh, but those payment people are really, you know, problem making for us because the HACCP scores and these other reimbursement things and, all the problems with that. So that's the quality reporting groups and the value-based purchasing groups, and it all falls under payment. And those could really be their own lecture easily. You could spend a whole day talking about the pros and cons of that. But it's come down to some programs of the carrot versus the stick. And I think we all remember that donkey thing where you got trying to get the donkey to move forward with the carrot versus, you're whacking them on the back with the stick. And that's really kind of the approach that I've kind of tried to explain CMS's philosophy on. So there, if you report your infections as a facility, you get points. If you don't do very well on your scores as compared to the rest of your facilities, you lose points. And by points, I mean reimbursement. So that's monies, right? And that really is what gets the attention of facilities as well as their administrators who actually make the decisions on where all these resources go. So when you're all talking about why can't we do and why can't we get, it's all resource based, and this really is helpful to driving those resources because people want to be not only look good for their community that they're providing great care, they're not having outbreaks, but also they want to stay on the top end of the reimbursement scheme. They do focus on the ones being the infections that are really most high, that have the highest mortality and morbidity. The CDC has been helpful in helping us pick which ones of those infections we should focus on. So it's been the CLAPSI, which is the central line associated bloodstream infections, the CAUTIs, which I know Sanjay talked about yesterday, the SSIs, MRSA bacteremia, and C. difficile, and then assorted, other SSIs keep getting added to the list. But they focus on these because they cause the most mortality and morbidity. Now, this is kind of becoming significant. I can tell you that as somebody who also teaches the courses back at UNC, I would have long-term care and hospitals during the training programs for infection control. And I would say, here's the studies. This is why you don't want to reuse a glucometer or a blood glucose meter from patient to patient to patient, because it drags blood you can't see and it's caused outbreaks. And I said, you need to clean these in between and disinfect, or you need to get a blood glucose meter for each resident in a long-term care facility, because almost all of them are having blood glucose checks, a significant portion of them. And they would say, oh, we just can't get support for that, And I would say, but there's been 3 outbreaks that I was involved with, and this many people died, and here's what the CDC says to do, and it's guidelines, right? So of course you want to do this. And they're like, yeah, we do, but we just can't get administrative support. And so it's really been a problem. So then we wrote a regulation when I got to be part of the regulatory writing in nursing homes that said, if you don't do this, you get an immediate jeopardy, which can close your facility and you're going to have to pay big money. And all of a sudden, within a month, everybody had a glucometer in their room and they were cleaning them in between. So, regulations can really help push some of all the goals that we, have expressed today in terms of moving forward with what we want to do. So in terms of infections, we do see that they're going down. I think Russ gave a great overview of how the infections are decreasing in most areas, except I think for the CAUTIs at this point, and Clostridium difficile, which is our other big one, which we'll talk about. Some special programs for that. But there are still facilities being penalized, and about 750 hospitals at the highest rates of infections are being penalized. They're sanctioned about $330 million per year. And then starting in 2015, and so now in 2017, we fully implemented all the money being given and the money being taken, and it ends up that they could lose about 5.4% of their total revenue from their 65% or so of the monies coming in from CMS. So it's not an insignificant number. And I say that because like the glucometer thing, when it becomes significant enough, they'll do something about it. I know that the talk around the tables in infection control are, well, we could buy this bell and whistle device, but if we do, it's going to cost us X amount of hundreds of thousands. We're only going to prevent 7 maybe infections a year, and that's only going to cost us this amount. And therefore, at this point, I think we'll wait and keep watching. We'll keep evaluating. And that's a lot of the way these things are decided, quite honestly. So that's how these things get done. Now, in terms of the quality improvement programs and the quality initiatives, there's been a whole lot going on trying to help hospitals actually achieve these great goals. They don't want to just penalize. They've been recognizing the need to help the facilities. And Don Berwick, who was head of CMS for a period of time, was actually very instrumental in bringing forward a lot of these quality programs that are right now still going. And one of them was called the hens, originally, the healthcare networks, the healthcare Russ, help me with that. Healthcare something engagement networks, I should remember. But now they're called the HINs, which is the Healthcare Improvement Innovation Networks. But they're working on the same things. They're working to help the acute care hospitals improve in the areas that they're getting cited for if they don't. And so they've given tons of money to state organizations to do all these improvement projects to with their focus of their work on those areas. There's also an organization called the QIOs and the QINs. These are quality improvement organizations and networks. There's 20 some of them now in the country, and they're actually independent of CMS but paid by CMS to help nursing homes and hospitals and dialysis facilities also achieve all these quality initiatives that we're working on. So they're called the Statement of Works, and they go for a period right now. The Statement of Work is from 2014 to 2019, working on these same things, the CDI projects and so forth. And so they'll actually do chart review, and then they'll do engagement with the facilities to improving. The facilities sign up, they're encouraged to sign up, and then they're given these opportunities, again, through CMS. So that's 5 minutes of quality overview, which again, any of those subjects could be a whole hour, but just to kind of round out everything that CMS is trying to do. Now, the areas that I'm most involved with is the conditions of participation or conditions for coverage. So one of the things that you should pick up on here is the fact that there are unique COPs for each type of setting. Hospitals have their own COPs. If you go into ambulatory surgery, which is a very evolving area now, they have their own COPs, and then you have the critical access hospitals. Some things overlap. Pretty much every condition of participation, which is the regulations, will tell you that you need to have a sanitary environment. But then it gets more specific into the details, depending on when they were written, because these are written over decades. These have to be approved by Congress, so they don't get changed very often. So they're written in very general terms. The reason they say you have to have a sanitary environment, whatever that means, because, and what my sanitary clean house environment is versus your clean sanitary environment is going to be very different. So there's a lot of room there for, surveyors to say what is and what isn't, facilities to say what is and it varies greatly by region to region. But that's because they only get updated by Congress. Like I said, it's literally an act of Congress to get these changed. And so it's a really big deal. Now, if you're involved, and some of you are, with dialysis facilities, that's ESRD is what they're grouped under at CMS, but they're dialysis facilities, and there's a lot of freestanding dialysis facilities basically under two big organizations, DaVita and Fresenius. And then there's long-term care nursing homes, which there's a lot of big corporations, and there's a lot of small freestanding ones. They really vary a lot in terms of their structure and organization and how much they're covered from state to state. And then again, the ambulatory surgical centers, and they're under the conditions for coverage. Again, regulations just given a slightly different name, but it's a little confusing when you see all these different things coming at you, what they mean. They all held the same weight. They're the minimum health and safety standards. And that's the thing that I really want to emphasize. It's the minimum health and safety standard. So, as someone coming in from infection control, from a university setting, I hit, CMS saying, oh, we should, do all these things. And they're like, those are best practices. And we have to, it's that line between when does something become a best practice, which certainly you guys are on the upper end of best practices for a lot of things we've heard about in the last 2 days, versus the minimal standards for safety, right? And that line is really a very, gray line moving back and forth in terms of what that is. But that's what they're looking for, the minimal standards. So where would they get the minimal standards from? CMS does not make up anything. They really don't. It's like, what does CMS say? Well, CMS says whatever our national organizations say. They say, what does FGI say? They say what the CDC guidelines say. They say what does ASHRAE say. So they don't say anything on their own. They go all to the guidance, national organizational guidance that's out there. And one other thing to take away from that is sometimes there's a lot of different guidances on the same thing. So AORN may say one thing, AMI may say another thing, CDC may say another thing. A good example of that was endoscope, how long they could hang between disinfection, right? Could they hang for 2 days? Could they hang for a week? Could they hang indefinitely? You'll have these expert panels that get together that determine these guidelines, depending on who wrote what paper sometimes, and also, you know, just their practical experience, and they try to make expert consensus on what should be recommended as a category 1 versus category 2 versus highly recommended or not. And it comes from that. But then if it's different, what is the surveyors looking for? They're looking for what the policy of that facility recommends. So if the policy of that facility says, oh, we follow CDC HICPAC guidelines, but then they're actually saying, well, we did what the ARN says, then they're going to get in trouble. So that's just something when you're in facilities and you're talking to them, be cognizant of, you know, this is where they can get into trouble. If you're promoting, I know this AORN guideline says this because they're most current. That's the nice thing about AORN is they're very current. They update theirs every couple years with the latest research. CDC is much delayed. Their guidelines can be 8, 10, 12, 15 years old. So they may be more outdated. What policy are they referencing? So when you're in facilities, be aware of that. Now, once they've written these very general regulations, then they have interpretive guidance that gets written to explain to surveyors how to enforce these. All right, so that's where we actually go to these national guidelines to see at the time what they should be looking for at that moment in time. Well, that's fine. I'm writing interpretive guidance right now for nursing homes, but let's say next year or the year after, of course, things are going to change, right? All these things are evolving. Then we write S&C memos, which are survey and certification memos, when there's been a frequently asked question enough, or when we get feedback that there's surveyors that are not surveying consistently, or there's a new guideline written that we need to update, we will write a memo. So we've written several memos. I gave an example yesterday in our group session about immediate use steam sterilization. It used to be called flash sterilization. Well, then the consensus group got together of all the leading organizations and wrote the immediate use steam sterilization consensus guidance. And it had every group on there that you could want to have on that group. And we wrote a memo that said, now you have to follow that because that's the most current guidance and you can't, you know, reference using flash anymore for X, Y, or Z. So I say that because this is a way to move things forward, right? This is a consensus group in a lot of things that we're wanting to do. And if we want to move things forward from activities like this, then we can think about doing that in a consensus way because that's what's something that CMS recognizes as being a minimal standard of practice then. So, so that's what they do. Okay, so this is the infection control CLP. It's very wordy. It basically comes down to doing these things for infection control. They have to have a person designated as the infection control officer as an IP. So every facility you go to, you will find at least one infection preventionist unless they're out there hiring someone new, which happens a lot as well. And then you have to find the quality person or someone else who's stepping in for that role. So there's always going to be an IP by rule. They have to have their delegation of authority in writing, which means that the CEOs tell them that, you know, they're supposed to be doing this job, that they were evaluated, that they can do this job. And they have to have documentation of their qualifications, that they've had the training, that they've got CIC, their certification in infection control, if they've been there more than 2 years, the other things that go along with their qualifications. And that then they're responsible for implementing the policies and procedures. This is important because if anything goes wrong in a facility, as all the IPs out there know, if anything goes wrong, if there's an outdated, you know, something in the back of a closet somewhere, it comes down to infection control is the reason why. You know, all the policies and procedures have to be written for every area, from the vending machines to the outpatient areas. Everything has to have an infection control policy. And they also have to make sure that they have a good surveillance system in place. So there's a lot of responsibilities with infection control. There's another rule that's somewhat new, but newer than infection control, and that's the QAPI, or the Quality Assessment Performance Improvement. When I first got to CMS in 2011, and I came back and started talking to people about QAPI or QAPI, they were like, what is that? It's just performance improvement under a new acronym, QAPI. So this is really everything in infection control is quality improvement, quality assessment, performance improvement, but it's making sure that that gets documented in a way that facilities get credited for it. So the nice thing about that is a lot of the things that you want to test and do in your facilities can fall under this quality QAPI kind of program, and it's another way of selling it to facilities is to use QAPI as the reason for it. So I mentioned that, of course, these rules get changed periodically, and we're actually in a period of time of we're trying to do that for hospitals. And when we do that, it's called the Notice of Proposed Rulemaking, NPRM, and that's where it kind of falls under the NPRM for the time that it's going through the system. So the hospitals right now are looking at new regulations for infection control that started June 13, 2016. The new requirements are theoretically going to save hospitals $284 million annually, and the rule includes reducing readmissions, improving care, and reducing HAI. So it's right in our area. And what does it expect us to do? So hospital-wide infection control, and what it's adding to the requirements, although about 50 or 60% of hospitals currently have it, it's adding to the requirements antibiotic stewardship programs. So a lot of the, particularly the bigger facilities, already have antibiotic stewardship programs to some degree, and it's kind of moving down to the community hospitals and so forth. And they're trying to figure out what the best system is for that. The CDC has guidance for that, and people are trying to figure out and fill in the details about it. So you have to have leaders not only in infection control, which we've had to have now for 20 some years, but now we also have to have antibiotic stewardship. And QAPI programs that are all incorporated together that can show they're working together to reduce these infections. Now, here's the one, and I put it in red because this is the one that should be like everybody should wake up for a second and say, competencies. Oh my gosh, because that's something that we haven't required. We've been educating out the wazoo for forever, right? Educating on hand hygiene, educating on how to do endoscope reprocessing recently. And what they realized with the endoscope reprocessing debacle of all those outbreaks that went across the country was that competency was what was lacking. All right, so we have all these cute little training programs, as was mentioned, but who knows that they're actually competent in what they do? Now, the one thing that CMS won't do is say how you have to implement that. All right, so you have to demonstrate that you're doing competencies, but they don't say how you have to demonstrate you have to do competencies. So there's a lot of debate about that, right? But anytime you're doing infection control training, if this rule passes, you'd have to then go back and show competencies. And also the other thing that's in both the new nursing home rule that's already passed, which includes competencies, and antibiotic stewardship, which isn't it something that nursing home rules already have a requirement for antibiotic stewardship, competency, and transition to care, but hospitals don't, because this rule is still waiting to pass. And you may have, I got to be so careful here. You may have noticed we're in a new era. So we're still waiting to see whether this is going to pass or not. It has 3 years to pass. We're now past year 1. If it doesn't pass in 2 more years, this whole new rule, which we took forever to write, will go away. And who knows when it'll ever come back. So a lot of rules have just faded away. So it's kind of interesting. I just have to say that and nothing else on that subject. Okay, so this is actually CMS Headquarters. A lot of people think, are you in Atlanta? Are you in DC? And interestingly, no, they're in Woodlawn. Woodlawn is outside of Baltimore. It's this giant building off the Beltway, kind of hidden away. It has about 10,000 people at it, of which only about 129 are responsible for survey and certification. I know. I was shocked as amazed too. That little arrow points to where I go when I come to visit, which I work from home. But if I would have moved to Baltimore, that's where my office would have been. And so that's where my boss's office is at CMS, Dr. Dan Schwartz, and he is fantastic. He's the chief medical officer for infection control there, and he is He is a urologist by training, but I'll tell you what, he could be an epidemiology ambassador. He is fantastic. And he does the legwork, the hard work of keeping infection control to the forefront of survey and certification issues and helping all these things move along and move through. So we're the team. I remember when I started and I said, so where's the team? And he said, we are the team. I was like, whoa, okay, no problem. So all the rest of those people are working on all those other issues that I talked about first, the quality issues, the quality improvement organizations, and all those other things. Now, the way that the Federal Surveying Certification Group works is, besides, trying to implement the conditions of participation that the reg writers write, who are in the rest of that building, is that they work with the accrediting organizations, and then they have 10 regional offices. So there's another couple dozen people out there. There's 10 regional offices around the country, and they deal, with the state agencies. So you can almost think of it like the CDC deals with the state health departments, who then deal with the local health departments. So it's kind of that same mentality. But the only federal workers are the CMS people in Baltimore or Woodlawn, and the regional office people. And I know ours is in Atlanta, our region, and I'm not sure where yours is. You guys probably know. Where's Michigan's office? Regional office, anybody know? Well, if you want to know, you can look at that website, and it'll tell you where all your regional offices are. And the state agencies, actually the state surveyors that come into all the facilities who do the certifications, they don't do the licensure, the states do the licensure, but they're often the same people. So the same people come in and license the facility to say that you can operate are the same people that come in and do the certifications for the federal agency. So states are licensing and federal is certifying. And so they're actually independent state workers whose salaries come from the federal government, but actually are paid through their own states for that work. So it's a contract basis what they do. And then we're responsible for making sure they get paid and everything. So CMS's mission and new processes. And so when they go into a facility, they don't just, the surveyors look at, oh, you're a Medicare beneficiary. I want to make sure your room is good. You're not, so forget your room. They really, when they go in and survey a facility, they're doing it for the benefit of all patients and residents in those facilities and all people who are paying for insurance, right? So one of the reasons why HACCP scores are important is because they're paying customers. So they want satisfaction, they want to get well, but they also want to have a good experience. And I think that's why I didn't have anything to do with HACCP scores. So if you hate them and don't think they're of any value, but the purpose of them was because they're paying customers and they are looking at value for their payment is the way that kind of came about. So old issues are coming back. We're getting a lot of feedback to us in terms of decisions we're making on burden reduction. So when we're making a decision about, do we want to say you can't do so-and-so based on this regulation, it's like, is that overburden or not overburden? We hear that with every decision we're making now. While also trying to fulfill the job to implement regulations. So it's an interesting time. In July, we did do with certification implemented a new pilot requiring the use of root cause analysis to replace plan of correction. If you come from a facility, you may be very familiar with that term where things went wrong or they were perceived that things went wrong, that you were cited for noncompliance with certain practices, then a plan of correction had to be written. But what benefit, and we have a new director of our certification group who said, he, in terms of witnessing this over his decades of experience, didn't see that was real valuable. So now he wants to do more of a root cause analysis type, which I think is a great idea, right? It's just a different philosophy in terms of how we fix things. Increasing transparency of the survey process. One of the things when we got in 2011, when I got there, we did an environmental scan of the surveyors, and we found that infection control could be an area of focus for increased education. And so now we're doing a lot of things to try to promote surveyor training in the area of infection control. It's one of the most cited in hospitals and nursing homes. It's #1 in nursing homes for decades, and very high up there in hospitals as well. And breach in infection control practices, which can be not minor to major, but it's always it's an easy one to find issues with, hand hygiene and all those things. So there's now a universal infection control course which is 16 45-minute to 1 hour lessons that surveyors can take and retake as much as they want to teach them the basics of infection control based on CDC guidelines for the most part. We started with the ambulatory surgical care course because that was the area that we first saw the most deficits and problems with, because they haven't been surveyed or looked at very hard, but they were really expanding rapidly and having multiple problems and outbreaks that the CDC was recognizing. So we did their course first specific to them, and then expanded this course so that whether you're in a nursing home, an outpatient setting, or a hospital, hand hygiene is hand hygiene, and we should all be doing it the same. So that's what this course is kind of talking about: environment cleaning, injection safety, all those basic practices on this universal course. Okay. The other thing that CMS does is really work with our federal partners. There's rarely any activity that we will do that we will not reach out to our stakeholders and get their opinions on. More so than you really probably realize. So we probably speak to CDC not daily, but nearly daily in terms of what's the latest outbreak, what's the latest issue, what can we do to fix things. So we're working with the CDC very, very closely on anything that comes out, from training issues to the worksheets we're going to talk about. FDA, when hand hygiene issues come up with products or radiologic agents, and it more complex it gets, the more difficult it gets to know what is minimum safe practices. AMI as well with their reprocessing medical devices. APIC, SHEA, ARN, AMDA, all these association organizations are where we look to for our standards of practice. And then the state agencies and regional offices, we're constantly in contact with them. What are you seeing out there? Tell us what your issues are, your questions are. And then the accrediting organizations as well we work with. So how do we work with the accrediting organizations? Actually, it's the one that most people know of is the Joint Commission. You had them here. I missed their talk, but I know that they, in terms of hospitals, go one of the 4 deeming agencies, which CMS, by memorandum of agreement, has agreed that they can go in and certify a facility every 3 years, and CMS will accept that as long as they're making sure that what they're surveying for are all the minimal standards. Now, they can go above that, and they often do. They often have higher expectations, or they're ahead of us in terms of expectations, and facilities pay a lot of money for that education and that look and evaluation. But what they have to do is at least do the minimal standards. So that's what we're always working with them on, is trying to stay in agreement with these little questions that come up. From the most recent one, I'll just tell you, is corrugated cardboard containers, shipping containers. Are they or aren't they allowed in food storage areas? Because we know they're not allowed in clean storage areas, but are they allowed in food storage areas? And is a food storage area cleaner? You would not believe the amount of conversation that can go on about something that simple. So anyway, we're working with that and making sure those kinds of things are always in alignment. CMS does validation surveys where they go back in and make sure that because Joint Commission does get paid for their services and CMS doesn't, that they're actually doing what they're supposed to be doing, and complaint investigations and so forth. They only do about 4%. So CMS is not in hospitals very much, except for complaints. On the other hand, in nursing homes, they're in all the nursing homes. Joint Commission doesn't do nursing homes. The state surveyors do. So there's a real difference there in terms of where the majority of our survey work is done from a CMS basis. If there is a problem, the AOs have to provide with a list of documentation for them, and they have to provide any kind of accreditation problems to CMS, so that CMS has a record of that. So the state agencies, what they do is they conduct inspections to certify that your facility has complied with the minimum health and safety standards, and they investigate complaints. They have to do so by a certain number of days, depending on that state. And then they do validation. And most of the time what they do is record review or observations. And so I've just kind of used hand hygiene as an example, but they're going to look for observations confirmed that the person is knowledgeable. So they're really going to the bedside here and talking to the folks who are actually doing the hands-on care. They're going to do parallel observations with team members to see if there's a consistent problem or just a problem with one person. And then they're going to do interviews with the staff as well as leadership, as well as residents or patients. And they're going to observe through all locations things like hand hygiene, injection safety practices. The things that have been cited the most are failure to clean hands before and after removing gloves, moving from patient to patient without cleaning hands and changing gloves, using alcohol-based hand rub on gloves rather than changing the gloves. Yes, that does happen. They think double gloving protects them against puncture injuries. So, those are issues. Not having gloves accessible in locations, the boxes are empty or they're just not there at all. So, like I said, we did this in a scan and we did notice that infection control training, I mean, that's all I do is infection control. It's all I've done for decades. It's still hard for me to keep up with all the current issues. So we were trying to help surveyors keep more current. And one of the things we've done is send them to the APIC courses and the annual conference. And we send, since 2012, about 50 state surveyors to the annual conferences and training, which 50, 50, 50, it's really starting to add up. We've also done a lot of webinars. In fact, I'm doing a webinar next Friday on Legionella, as you know, with the new S&C memo that's come out that I'm going to talk to at the end. And then universal infection control courses for ASCs, for home health, and for just in general. And then provider training. So one of the things we've opened up is all these trainings are going to be open to the public so that facilities can see exactly what the surveyors are getting for training so that they can be in alignment, right? Because that's often been the problem. The surveyors are like, we're looking for something and we're not telling you, and we're not doing that anymore. We're like, we expect you to do these things, and we're telling you right now they better be there when we get there. So that's a kind of a new philosophy. So CDC and Survey Insert have worked together on a lot of things in the last 10 years, and particularly this started with ambulatory surgical settings when they started the pilot study. Does everybody remember the big outbreak in Nevada in the endoscopy clinic where thousands of people were exposed? Well, that started that collaboration. They did a 3-state study, which included our state, North Carolina, and found all kinds of infection control problems from hand hygiene to injection safety. And that started the whole ball of moving towards having surveyors focus on infection control issues. And then hospitals piloted their worksheets in 2011 and started in 2014 with the final sheet. And then dialysis started with their infection control, which I think made a huge difference for them through an ARC study from 2012 and finalized in 2013. And so we're in the process of updating the hospital worksheet, which we put out in 2014. ASCs, they do random, about 450 random electronic submission use of the worksheets. Dialysis has been using them on all surveys since 2013, and we're currently creating a draft through a pilot study for nursing homes, which is, a huge improvement. And why is that a big improvement? Because it does increase transparency of what we're doing. So that people can see what we're doing. In an effort to increase our transparency, all the CMS issued survey insert memos regarding complaint data has been now made available, accessible on websites, for both acute care and the CAHs, which are community access hospitals. So when you get a complaint and then somebody comes in and surveys you and finds a problem, or they're just doing a regular survey, they call it a CMS 2567 deficiency. That's just a form number, and it happened to be the number that ended up for you did something wrong. And it'll list the tag numbers that says what you did wrong. And so it doesn't go into the details, but you can ask for that on the Freedom of Information if you want to. So the vision for infection control worksheets are to create a tool that promotes infection prevention in hospitals. We really want to see consistency. We know that from state to state and region to region, there's differences in survey process. And so that was a problem that kept coming back up again, and we think these worksheets are very helpful in making consistency, looking for best practice. So the tool is available free online. Again, we started in 2011, and we're updating it now, but that worksheet can be pulled off the internet, both the 2014 worksheet, which, I've gotten a lot of feedback on how helpful that's been to facilities. I'll tell you in a second when I get to the pilot study that, what we have found is that when there were a lot of problems with consistency and not only from the surveyors, but from facilities, that once they had that worksheet and they knew what they should be doing at a minimum of practice, which is always, all that worksheet is Category 1 recommendations from CDC guidelines. You go to the CLAPSI, you go to the pneumonia guideline, you go to the environmental guideline, you go to isolation guideline, you name a CDC guideline. We took Category 1 recommendations from there, unless they were outdated, and we put them on the worksheet. These are all minimum things people should have been doing anyway. And what I was told is how helpful that was for IPs to take to their administrators, so that if there was an area where they weren't getting, support, that they could get support because they knew CMS was expecting it. So now we've expanded the new worksheet to the pilot study to include these NPRM requirements of competency and transitions of care, which we know is a big problem. We did a TEP, a technical expert panel, and we had the nursing home and hospitals, and they were shocked when the physicians started talking back and forth about how when we move a patient, it may be 3 days before that antibiotic gets to that patient because they don't have a pump. They have to order the antibiotics off site. They don't know what they're getting when they come back. So all this has been, we're dealing with all this now through forms and documentation and treatment. So we're really making improvements. In terms of what that worksheet looks like, this is just a small, I don't expect you to read it, but I just wanted to show you 40 pages. This is what just hand hygiene looks like. It's taken from the CDC hand hygiene guidelines and the World Health Organization guidelines for hand hygiene. So it's the Category 1 recommendations from that. Yes, no, you're either doing it or you're not doing it. So the survey tools, they're not using them in 2017 because we're in the process of updating them. The ASC tools are still going to be used in full surveys, and we talk about ESRD. The pilot study. So because of these new regulations in nursing homes and the new regulations that we hope will come out in hospitals, we, through Ebola funding, created this project to update, include the transitions of care, revise the guidelines, make them more transparent. Again, you can download this off the website if you want to see what this worksheet looks like. And we've done 10 pilot studies in 2016. We revised the tool, tweaked it a little bit. We've gone into 40 hospitals and 40 nursing homes who have the highest rate of transfer. And we've looked at, where the problems are by matching the hospitals and nursing homes together back and forth. It's most important for transition of care, right? And then we've provided technical assistance about how they can make improvements through phone calls. We've hooked them up with the HAI coordinators in their state and the QIOs, QINs in their state. And we're going to recheck in 2018 whether they've made improvements or not. I can tell you hospitals did great. Hospitals were just phenomenal on these 40 facilities. They scored, the only thing they didn't score on well, does anybody want to guess? What do you think they not scored well on? Competencies. They'd never been required to do competencies. Nobody's doing competencies, right? Because there wasn't a requirement before, and now it might be. Now it might be. Okay, so yeah. So the other thing they're doing is surveyors have their own association. They're called AFSA. Association for Healthcare Facility Survey Agency. So there's thousands of surveyors across the country, and they want to get in on the action too. They want to prevent infections. So they want to do a project. We're working with CDC, and we're working on RUS. We're working on CDI. We're working on Clostridium difficile. Yay! So we're looking at hand hygiene. We're looking at duration of isolation, environmental cleaning, antibiotic stewardship, and infection control during transitions of care. So those are the main areas that they're going to. We don't exactly know what the project looks like yet because we're developing it, but it's going to be a project led by the state surveyors in the states that have volunteered, and I think there's 20-some states that have volunteered to do this. I'm going to finish with Legionella. I didn't realize how broad this topic, I thought it was going to be kind of hand hygiene focused. So I just threw this together during break, this slide, so that you can bombard me with questions. Like I said, I've been working for 2 weeks on this webinar I'm going to be doing next Friday, which after I do the webinar for all the surveyors and all the AOs across the country, it'll be public in a month or two on the MLN, the Medical Learning Network website. So like I said, all the trainings will now be available on the MLN, so you can see what the surveyors are hearing. And this too, eventually, when they get it all, repaired and whatever, they'll make that available. So I just jotted a few things down that I thought, might stimulate discussion. One is the fact is that the Legionella S&C memo came from the fact that we've seen a 300 or so increase in reported cases for whatever reason. all kinds of reasons. We're recognizing it more, we're testing more, the environment's changing, all the things that we've proposed all probably play a role. Our systems are getting older. And what they then said, so CDC came to us and said, we're having all these outbreaks, there's all these increased cases. This is the kind of thing that we're going to write a regulation about and give some guidance about. We're actually not writing a regulation, but more interpretive guidance about, right? Because it's a new problem. So what they wanted us to do was make sure that ASHRAE 188, and of course ASHRAE 188 was translated by the CDC into a toolkit to make it more digestible. And that's what the S&C memo is asking for, a risk assessment. The risk assessment should be based on the premise plumbing. We all heard about that, the age of the building, how many dead legs, all the problems you've had in the past, blah, 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 the premise plumbing. And then clinical equipment, what are you using in your facility, anything from as simple as an ice maker to the heater cooler devices to, all those things where are they clean? Are you following manufacturer's instructions? That's the other thing I want to emphasize. Besides the fact that you're going to need to be in line with whatever guidance you say, the other thing that CMS looks at, all the surveyors look at all the time, and they're required to look at, right? So even if you disagree, they want to see what the manufacturer's instructions for use say. So, unless you've got a CDC guidance that supersedes or an FDA guidance that supersedes or an EPA guidance that supersedes manufacturer's instructions for use, you better be following manufacturer's instructions for use. That's what the surveyors are going to go by. I say that because that's what really is about the patient care equipment issues, right? Are you keeping, is the patient care equipment being handled and maintained in a way that won't allow for, growth of pathogens? Because it's not just Legionella, as we've heard, it's Pseudomonas, it's Acinetobacter, it's Burkholderia, it's all these things. So it's all included. Plus, the other third component of your risk assessment is the high-risk population. Do you have solid organ transplants? Do you have bone marrow transplants? What's your risk population? So the risk assessment, while there's not one that's neatly been made for us so far, there's one that the public health departments kind of use as an evaluative tool when there's a problem and it's more environmental based. It's going to be much like an ICRA, right? So we already have had experience with that. You're going to put these groups down. And then you're going to say, do I have them or not? And then 1 through 3, are they, what are their risk? And come up with your risk assessment. It's really also part of your water management program, which is a 7 steps. And I don't know if I can say all 7 steps off the top of my head, but they've been discussed. Do you have the right people on your team? Do you need outside contractors if you don't to supplement? Have you evaluated your premise plumbing? Have you evaluated your equipment? Have you looked at the clinical limits of disinfectants, water temperature, testing? Is the water clean? Heterotrophic plate count under 500. Combination of these control measures, have they been evaluated? Are you at risk? Do you have a history of problems in the facility? And then clinical surveillance. So all these need to go together, right, as part of the water management plan. And then that will determine the additional specific testing protocols if one of those things aren't in line. So if you can't get them in line and you don't have them in line, that's when then clinical testing of Legionella, which has to be done by specialty labs because hospitals can't test for Legionella that I know of. So that's that kind of summarizes that. It's all based on the environmental guidelines. Good. It's all based on the environmental guidelines for temperature, how cold is cold and how hot is hot, which I don't remember off the top of my head, and the pneumonia guidelines for if they see a case, what to do, if they have somebody that in the facility is being under treatment for bone marrow or not. So that's very helpful. We're still using the 2003 environmental. We're still using the 2003 addendum 2004 pneumonia guidelines for that level of detail. Additional information, if you want to go find a lot of survey and certification memos on infection control, you can go look at that website. It's fascinating reading. If you want to go look at the interpretive guidance, if you want to look up the regulatory guidance, there you go. All right. So I know I probably would do this a little differently had I got to hear this before I came, but I hope this was helpful to you. Thank you very much.
Okay, thank you, Karen. That was great. Before we open up to Q&A, we just wanted to make sure we got the webinar information to Christine so we can share it with the whole team.
You can blast it out. Okay.
Okay.
Well, my favorite part is questions. So,
okay.
so I'm not just talking. Yeah.
Okay. Right in back you.
Right in back.
Hi, thank you. A question on best practice for hand hygiene monitoring in ambulatory care, especially clinics, where you have one clinician in the room at a time with a shut door.
So CDC does, or CDC, CMS doesn't tell you how to do policies and procedures. None of this will they tell you how you have to do it, right? So what are you referencing for why you're doing what you're doing is why you should be doing what you're doing. So if you can document that you're looking at them going in and out of the room, then they're good with that.
I think it's really hard to document because people go in and shut the door,
I got
sanitize, greet the patient.
I know.
So.
John's got an idea for that.
The WHO guideline on hand hygiene in outpatient facilities suggests that in outpatients where there's clinics and people are going into the room and exam room and shutting the door, that maybe the only practical thing to monitor is whether or not they're doing hand hygiene on the way into the room, which would be moment one, which they felt might be the most practical thing to do. And so I'm guessing that if your hospital or your ambulatory site states that that's the way you're going to monitor hand hygiene in an outpatient setting, and if you're doing it, that presumably would be okay.
That would be fine. Again, it would have the support of a guidance, and as long as you were documenting it. I think where a lot of people fall down in a lot of infection control issues with the surveyors is they don't document. They're doing a lot of things, but when surveyors come, they can't always show it. So saying where you got your information from, the WHO, why we're doing it, and then actually having documentation, that's going to be really important for the Legionella work, especially is documenting all these steps. Again, not that they're not doing it, but that they can't show evidence of it, you know, in a paper form or some form. Thank you.
I asked this question yesterday when we talked about disinfection and just talking about the IFUs. And what I brought up yesterday is getting into that catch-22 where different IFUs are recommending or saying that you can only use certain disinfectants. So then we have 15 or 20 different disinfectants and expecting the end users to know how to use each of those disinfectants.
Yeah.
So I just wanted to get your comment on that debacle we're in right now.
I agree it's a debacle. So options. I mean, from a CMS perspective, you would have to follow what the manufacturer's instructions would say. Having said that, I would go to the manufacturer. An option is to say, if you want me to continue to purchase your product, then you can put in writing that I can use this other thing. All right. If they're willing to put in writing, and I can't say why they're actually choosing that product, but we can guess what the benefits that might be. But what they can do is say, yes, this equivalent product is okay for you to use. So if you can get that in writing from the company, that would be acceptable to CMS. And you can always purchase from another company, right? So, I mean, that's always your option. Some company that doesn't do that.
Okay.
So we recently had a number of deaths directly related back to the laundry. We've seen clinical research recently related to the contamination of the fabrics coming back from the laundry. Can you give us an indication of what the CMS thoughts are on addressing those set of issues?
All right, so you've got contaminated laundry coming back. So, so what it says for laundry is what the CDC guidance says. It has to be wrapped. You have to, protect it coming from the facility back to the agency. So it's got to be covered in some form or fashion, which is where most of the contamination is occurring. Is the contamination occurring in your laundry facility, or is it in transport? So those are all things that would need to be evaluated. Or in storage when it gets there, sitting on this loading dock, which is where most of the contamination's been found in the past, or in the storage areas where there may be water contamination. Because a lot of these storage areas are in basements. So, you know, when we've gone in and looked at this in the past, it's if it's not in the loading docks, it's in the storage room. And so you just have to break down where the problem is and then solve it. The requirements from CDC are that laundry is sanitary, hygienically clean, and then covered to protect it on its way from being in a facility where it's reprocessed to the patient. So there's a lot of steps there in between, right?
Having done some laundry evaluations, having looked at quite a few, well, actually 3 or 4 clusters of infection associated with laundry, one of the things that we see really to be an issue is wet laundry. Mm-hmm. They're putting the laundry, they're packaging it up at 80 degrees and then taking it outside at 32 degrees. And with the laws of physics saying that air holds 50% more moisture when there's a 23-degree shift in air, you can get condensation, even though it might indicate dryness in the laundry, and it ends up being wet. So it's one of those subtleties that we've got to deal with eventually.
Yeah.
Okay, next question.
Different topic, or back to the Legionella.
Yeah.
So I want to ask what I should be asking for from the different acronyms and things you said. So Dr. Reynolds and I are the content experts on the CDC's online training program. It's not going to be released for several months because we're going in for clearance of how that's being created.
I know, we're in the same timeline for me trying to get release of documents by next Friday.
So we had an idea of actually maybe assisting in what I think you call the interpretive guidance and creating a checklist, which would maybe be similar to the hand hygiene.
Yes.
Would that be helpful to approach CMS through CDC to talk to Dr. Schwartz about that, since we wrote that and there's going to be templates and things coming out so that they could obviously take the online training, but I feel like a surveyor's not realistically going to be able to take that training and immediately go into the field and be asking for the level of detail of documentation. So we were just thinking about, we called it a checklist, but what would we actually be talking to Dr. Schwartz? What would be our key terms that we would ask that we could assist with? Does that make sense? Am I making any sense?
Yeah, and I think we could talk offline about that.
Okay.
Because Laura Cooley, I'm sure, is who you're working with, and Matt Ardino and those guys over at CDC and the water program is who we've been working with. And so we're always open to trying to help the surveyors have a better understanding of what they should be surveying for. Because, you know, it's really terrible when they go in and, you know, they learned whatever they learned wherever they learned it, and then, you know, it's not right.
Right.
So we want to be right for all the right reasons. and so, yeah, we definitely, should exchange information. Thank you. Yes.
Hi, thank you. Jimmy Walker again from Public Health England.
Yes.
Sticking with Legionella, thank you very much for your talk, by the way, and yes, I would like the link for your webinar. But thinking about Legionella and the different types of Legionella in water systems, what's the advice? For example, we know Legionella serogroup 1, Pneumophilus serogroup 1 is the organism that causes the most infections. What's the advice if it's not Pneumophila? And what's the advice on the numbers present for the vulnerable patients?
So I'm sorry, I'm just having a little trouble with your accent. What's the question?
So Legionella pneumophila,
yeah,
serogroup
it's
1.
about 65% of or more, right?
Sure.
Yeah.
So for the results that are coming back from the water, if it's not Pneumophila serogroup 1, but it's Bosmoniae or it's Anisa, what's the advice you give to the people who have to act on that?
Yeah, that's a really good question. So, you know, we don't probably going to get to that stage unless, you know, there's actually clinical surveillance with the Legionella problem. So they'd probably act on cleaning that water. That'd be an indicator the water had some issues and we maybe just missed, you know, it's hard to find Legionella, to be quite honest. So we'd want to go ahead and act on that because if there's surveillance cultures, clinical surveillance, that it's problematic disease-wise in the patient population. The weird thing about Legionella, which you experts in the room know, is that there can be very small numbers, and then there can be cases. There can be very large numbers of Legion, and there can be, you know, no cases. So it's not your typical dose response kind of disease, which makes Legionella recommendations pretty tricky business for everybody. And so, yeah, it's not as straightforward as what we'd like. And so I think we rely more on clinical surveillance at this point until we get better. understanding of some of these issues. The other thing that's really weird about Legionella is oftentimes you have 1 or 2 cases which can be missed. It's not until you get like multiple cases where somebody starts saying too much Legionella or too many pneumonias, let's look a little harder, and then you find out there's a cluster of Legionella, and then those are the ones that get reported, but there's probably underlying cases of Legionella pneumonia going on all the time, but just going unrecognized. So that's always troublesome to me to think about. So I try not to think about it, but that's also something that we're gonna, as we get better at doing all this, that we're gonna have to hopefully get tuned into. This is a step forward, though, right?
Karen, thank you very much for your time. Really appreciate it.
Thank you.